Hey everyone, welcome back to The Explainer. I am absolutely thrilled to have you here today because, well, we are tackling an absolute heavyweight of a pathogen. So grab your coffee, get your notes ready because today we're diving into a high-yield study session on Francisella tularensis. That's the bacteria responsible for rabbit fever. Whether you're prepping for board exams, gearing up for rounds, or maybe you're just fascinated by serious infectious diseases, this explainer is built to give you exactly what you need. No fluff, just the high-yield clinical facts.
Here is our quick game plan for today. First, we'll meet the pathogen, then we'll cover routes of transmission, third, we'll break down the key clinical presentations, and finally, we'll wrap up with treatment and some absolute crucial warnings.
All right, part 1. Let's meet the pathogen.
Okay, I really need you to burn this number into your brain right now. 10 to 50. Just look at how incredibly tiny that is. This represents the infectious dose of Francisella tularensis required to cause an infection if it gets in through the skin or via inhalation. Just 10 to 50 organisms. To put that into perspective, that is literally one of the lowest infectious doses of any known pathogen. It's just terrifyingly efficient at setting up shop in the body.
So what are we actually dealing with here? Well, Francisella tularensis is a small, gram-negative, pleomorphic cocobacillus. It's aerobic, and crucially for your exams, it is a facultatively intracellular pathogen. It was actually first described way back in 1911 in California as they called it a plague-like disease of rodents, and it was later named after Edward Francis. Now, because of that absurdly low infectious dose we just talked about, this bug requires a BSL-3 laboratory to culture it safely. It's an HHS Tier 1 select agent, which basically means it's a recognized bioterrorism threat. But here's a massive sigh of relief and a huge board exam pearl. There is absolutely no human-to-human transmission.
And this breakdown brilliantly illustrates how the pathogen is geographically and genetically split. We've got two main subspecies you need to track. Type A, which is subspecies tularensis, is found only in North America. It's definitely the more lethal of the two, and it's usually associated with rabbits and ticks in dry environments. If you get hit with a microtrivia question, Type A is the one that ferments glycerol and is citrulline uridase positive. Then you've got Type B, or subspecies holarctica. This one is found in North America, Europe, and Asia. It's less lethal and it tends to hang around semi-aquatic environments involving muskrats and beavers.
Moving right along to Section 2, routes of transmission.
How do people actually get this? Well, the epidemiology here is kind of all over the place. First up, arthropod bites. In the US, you really want to think about ticks, specifically the dermacenter tick, and deer flies. In places like Scandinavia, even mosquitoes can transmit it. Second is direct contact. A classic clinical vignette is a patient handling infected rabbits, hares, or muskrats. Think of a hunter skinning an animal. Third, inhalation of aerosols, which, as we'll see in a minute, is extremely dangerous. And fourth is ingestion. Now, while peak incidence is usually in the summer when ticks are super active, a really cool piece of exam trivia is that in Turkey, outbreaks actually peak in the winter, and that's due to people drinking contaminated, non-chlorinated spring water.
But hey, remember that crazy low infectious dose we talked about earlier? Here is a massive curveball for you. If the bacteria enter through the skin from a tick bite, or if they're inhaled, it really only takes that 10 to 50 organisms to make your patient severely ill. But if the route is oral, say drinking that contaminated water, the required infectious dose just skyrockets to between 1 million and 100 million organisms. Your stomach acid puts up a really great fight, but the lungs and the skin, they're basically wide open doors.
All right, let's jump into Section 3, key clinical presentations.
Let's walk through this high-yield table together, and feel free to pause if you're taking notes. Notice how perfectly the clinical form lines up with how the pathogen actually got into the body. If it comes through the skin, you get ulceroglandular disease, which is nearly half of all cases. If it's inhaled, you get the pneumonic form at about 17%. Eye contamination leads to oculoglandular, and ingestion leads to oropharyngeal. In all of these forms, after an incubation period of anywhere from 1 to 21 days, though it's usually more like 3 to 5, your patient is going to hit you with a high fever, a massive headache, and myalgias. Historically, you might have seen a typhoidal category for systemic disease without a local lesion, but honestly, infectious disease experts want you to avoid that term now since most of those cases were probably just inhaled.
Let's zoom in on the most common presentation, the ulceroglandular form. The defining feature here is a skin ulcer right at the site of entry, paired up with extremely tender regional lymphadenopathy. So the really crucial point here is that while the lymph nodes are super painful and tender, the primary skin ulcer itself might actually be totally painless or minimally symptomatic. You, as the astute clinician, might really have to do a careful full-body physical exam to actually find the bite mark or the ulcer hiding out on their skin.
Now I need you to sound the exam alert in your head for this next one, the pneumonic or respiratory form. This happens via inhalation of aerosols, maybe from contaminated hay or grain. Guys, this is the absolute most lethal form of the disease. It carries the highest rate of bacteremia. Patients are going to present with a dry cough, usually starting about a week after the fever, and imaging is going to show mediastinal or hilar lymphadenopathy alongside consolidation or pleural effusions.
I also want to just really quickly touch on this highly specific, highly testable 2% presentation, the oculoglandular form. This happens when a patient is handling an infected animal, maybe they've got the bacteria right on their fingers, and then they rub their eyes. This leads to severe conjunctivitis paired with pre-auricular or peri-auricular lymphadenopathy, so swollen nodes right in front of the ear. When you see this highly specific combo, look for the board buzzword Paranod oculoglandular syndrome.
And that brings us to Section 4, Treatment and Crucial Warnings.
Look, if you spot tularemia and initiate the right treatment, you literally increase the patient's odds of survival tenfold. It's a game changer. The drugs of choice are fluoroquinolones like ciprofloxacin and levofloxacin, aminoglycosides like gentamicin, or tetracyclines like doxycycline. Now, if you're flipping through some older textbooks, you might actually see streptomycin listed as the historic first-choice drug. And while it definitely works, it's heavily deprioritized today. Why? Well, it's only available IM, it's really hard to get a hold of, and it is just significantly more toxic than our modern alternatives.
But right here is where I need you to adopt a very, very serious clinical mindset. Do not, and I mean do not reach for a beta-lactam. All beta-lactam antibiotics, that includes your penicillins, your cephalosporins, and your big broad-spectrum carbapenems, they have absolutely zero efficacy against Francisella tularensis. Literally none. Clindamycin also lacks efficacy. So, if a patient comes in with severe pneumonia or a nasty skin ulcer and massive lymph nodes, and you empirically blast them with ceftriaxone or a carbapenem, you are essentially giving this bacteria a free pass to kill your patient.
Let's wrap up our clinical management with a few high-yield logistical pearls that exam writers just absolutely love to use as trick questions. First, because there is no human-to-human transmission, patient isolation is not required. You don't need a fancy negative pressure room for the patient. However, you absolutely must alert your microbiology lab before sending any samples down. Processing those cultures requires mandatory BSL-3 precautions. The lab staff are at huge risk here if they don't know what's coming. Next, if treatment is delayed by more than 2 to 3 weeks, about a third of your patients are going to develop a lymph node abscess that will require surgical drainage. And finally, beware of macrolides. Resistance is super common in Europe and Asia, so do not use them empirically unless you have a confirmed type A strain in the US and you're specifically using azithromycin.
To finish up, I want to leave you with this really fascinating, honestly kind of terrifying clinical scenario. Just imagine a patient from an endemic area presenting with a dry cough, lung nodules, and huge hilar lymph nodes. You order a PET CT scan, and it lights up like a Christmas tree. Your immediate thought is lung cancer, right? It has to be. But here is the trap. Pneumonic tularemia causes intensely false positive PET CT scans. Before you send that patient for an invasive, potentially dangerous cancer biopsy, you really have to ask yourself, could this be rabbit fever? It is a total diagnostic minefield, but with the tools we've covered today, I know you're ready to spot it. Stay vigilant out there, keep reviewing these slides, and I'll catch you on the next explainer.